Quick question, what diagram would you draw to help you explain graded exposure in your CASC exam? Graded exposure and systematic desensitization. Hi everyone, I'm Dr Clarke, MRCPsych, and welcome back to Pass the CASC. Today we're looking at a really common anxiety-related station, explaining graded exposure and systematic desensitization to a patient with agoraphobia. This station is a brilliant test of your abilities in explaining therapy clearly and calmly, and it's an easy station to secure those excellent pass marks if you know what examiners are looking for. Watch on to find out exactly what that is, and make sure you too pass this station in your real CASC exam.
You're seeing Miss Carter, a 43-year-old woman with severe agoraphobia who hasn't left her house for almost a year. She's managed to attend your clinic with her husband today as she is desperate for help. She's been taking sertraline for the past 18 months and also tried online self-help in the past, but with limited progress. Your task is to explore her previous treatment experiences, discuss a new treatment plan collaboratively, and explain graded exposure and systematic desensitization in a way she can understand. In just 1 minute, you'll see how this simple diagram becomes a powerful tool in your explanation, making it clearer, more visual, and far more memorable for the examiner.
Hi Miss Carter, thank you for coming in today. I know it's been really hard for you to get to appointments, so I really appreciate the effort you've made. What I'd like to do today is hear a little bit about how things have been going, what's helped and what hasn't, and then think together about the best next steps to help you feel better as soon as possible. Does that sound okay?
This opening scores highly because it shows empathy early on by acknowledging her difficulty in attending, sets an agenda for the review which addresses all of the station's tasks, and checks permission before proceeding with the review.
I understand you've been taking sertraline for about 18 months and tried some self-help groups online as well, but it sounds like these haven't made as much of a difference as you'd hoped. Can you tell me a bit more about what you found helpful or unhelpful about those approaches? I understand that whenever you try to leave the house, your anxiety becomes really intense. Your heart races, you might shake or feel dizzy, and staying inside brings relief, at least for a short while. That reaction makes perfect sense. It's your brain trying to protect you from what it thinks is dangerous. The problem is that each time you avoid going out, your brain then learns that staying at home is the best way to keep you safe. So the fear of going out grows even stronger next time. The good news is that we can retrain this response through therapy. Would you like to hear a bit more about how we do that?
This section demonstrates a clear understanding of the anxiety-avoidance cycle which perpetuates agoraphobia, and examiners often mark this as a key knowledge point for the station. It also shows great empathy and naturally leads into your explanation of the therapy.
One proven approach is called graded exposure. In graded exposure, we would make a list of steps together, starting from the least frightening right up to the most anxiety-provoking. For example, standing by your front door and thinking about going out could be step 1. Then opening the door could be step 2. Step 3 could involve standing outside for just 1 minute. And then step 4 might involve walking to the end of your garden path, and next to the end of your street, and so on. Each step is practiced until your anxiety naturally fades, and it always does. You see, the anxiety is guaranteed to build up at first, but if you stay with it and don't escape the situation, it will then gradually go down too. Over time, your brain learns that the feared situation isn't actually dangerous at all because you don't come to any harm, and this process is called habituation. Does this all make sense so far?
Use your diagram now in order to help consolidate the learning point. This graph shows how anxiety naturally rises when you first face a feared situation, then gradually falls if you stay in the situation without avoiding it. Each curve represents a repeated exposure, the first, second, third, and fourth attempts. Over time, the peaks become lower and the anxiety reduces more quickly. This visually demonstrates how graded exposure leads to habituation and helps the brain relearn that the situation is not dangerous. It's a clear way of showing patients and examiners exactly why this therapy works. This section is gold for CASC marks. You've clearly and confidently described how graded exposure works using simple language, logical sequencing, and an everyday example which the patient can easily visualize. Examiners love when candidates use a stepwise fear hierarchy example. It shows true understanding of how the therapy works. Explain the rise and fall of anxiety using the habituation curve, which shows theoretical knowledge. And emphasize that exposure is gradual and collaborative, not overwhelming, which demonstrates empathy and safety awareness.
We also practice something called systematic desensitization, which is very similar. The difference is before facing each exposure step, we practice a relaxation technique, like slow breathing, muscle relaxation, or guided imagery. The idea behind this is that it's very hard to feel deeply relaxed and also highly anxious at the same time. This method teaches your brain to start linking the feared situation with calmness and relaxation instead of panic and fear. Over time, this method helps the fear drop even further than with graded exposure alone.
You should mention both graded exposure and systematic desensitization by name. Examiners specifically award marks to candidates who can differentiate and explain them both with confidence and clarity. In your CASC exam, you can gesture calmly with your hands or take a deep breath when describing relaxation techniques, as this models the calm tone that the therapy itself promotes.
The key idea behind both therapies is that avoidance keeps anxiety going, and gradual exposure reduces it. I also want to reassure you now, this is not about throwing you in at the deep end. It's about moving one small supported step at a time, going at your pace, until your confidence naturally grows and your fear shrinks. I really love the sense of hope and reassurance that this line brings, using the opposing imagery of confidence growing whilst fears shrinking. This helps the patient connect with the therapy's purpose in an emotional and memorable way. We'll always make sure that each step feels manageable and not overwhelming. If your anxiety ever feels like too much, you'll have practical coping strategies like breathing techniques, support from your husband, and a direct contact number for our team. You can also call the crisis line or 111 if you ever feel unsafe or have any thoughts about harming yourself. The key is that we build confidence gradually and at your pace. Does that sound okay?
Always mention safety and escalation in therapy stations. Therapy can sometimes heighten distress before improvement occurs. Acknowledging this and outlining clear safety measures demonstrates clinical insight, risk awareness, and safe practice, earning you top marks in the exam.
You've done exactly the right thing in trying medication and self-help first, but I do believe that you'd now benefit from more structured therapy, using graded exposure and systematic desensitization. We can start gently with sessions at your home or with your husband accompanying you here, whichever feels safest at first. I'd also suggest continuing your sertraline for now, as it may still be giving some benefits and can make the therapy process a little easier. We'll also keep checking in on your mood, so if any hopeless feelings worsen, we can respond and support you right away. How does that sound to you?
Use shared decision phrases like, "How does that sound to you?" or "Would you feel ready to try that?" to make the patient feel included and empowered. Examiners reward this collaborative approach highly.
I know that I've given you a lot of information today. Does it all make sense so far? Do you think that these therapies might be worth trying? I genuinely believe that with the right support, you can make gradual but very real progress in rebuilding your confidence and independence. I really like this closing because it brings together warmth, structure, and hope. By acknowledging what the patient has already tried, you validate their efforts and avoid sounding dismissive. The phrasing, "How does that sound to you?" reinforces shared decision-making and signals genuine collaboration. Tick, tick on the examiner's mark sheet, ending with a line about confidence and independence, also leaves the patient and the examiner with a sense of optimism and therapeutic process. Exactly the emotional tone you want to end on.
The approach demonstrated in this video works really well as it shows empathy and validates anxiety, explains the anxiety-avoidance cycle clearly, outlines and distinguishes between graded exposure and systematic desensitization, mentions habituation and relaxation techniques, and emphasizes safety, pacing, and collaboration.
When you put all this together, a clear structure, empathy, and simple language, you'll show the examiner that you can both educate and reassure even under exam pressure. Try practicing this with a peer. Draw and explain the anxiety habituation curve, outline the steps of graded exposure and systematic desensitization, and finish with a collaborative plan. If you can do all that calmly, you'll absolutely stand out in your CASC exam. If you made it this far, then please do go ahead and give the video a like, subscribe to my channel at Dr Clarke, and drop a comment telling me exactly which CASC topics you'd like me to cover next.
If you found this video helpful, then please do consider subscribing to my channel. Your support really helps me keep creating and improving these videos. Thanks.